growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi, everybody. Dr. Steve Rasner back here at the Lionhearted podcast. Again, this is a week where I hope that you just listen to me and aren't tuning in to see me because I look like a mess. I just played tennis a few hours ago. I have a bird's nest on my head. That would be called my hair. And it doesn't matter. I know you didn't tune in to look at me. So I told you in the last podcast that today I wanted to talk about a very specific patient that we have in front of us all the time these days, it seems. And I think there's a reason for me to talk about this particular subject, and that is the patient that comes to you that's going to lose either a lot of teeth or all of their teeth. They may or may not know that, but that patient needs to be handled in a very specific way. So you can consider this podcast case presentation skills for that patient, because it is such an amazing, impactful moment in both of your lives, you know. And one of the reasons I think that this is such a big deal is because, let's be honest about it. If you go back 5 years ago, television and print ads were not so infused with commercials about teeth tomorrow, all on 4, and these concepts that are really speaking to patients that are going to lose a lot of teeth. And so patients have a lot of decisions to make, and if they land in your office, I want to help you prepare for a great way to transition them into the conversation. And I think I can do that very well for you. I am Dr. Steve Rasner, and you can reach me by email. And lots of you do that these days. And my email is drrasner@AOL.com. And you can find out my courses, my schedule, if you want to come to Jersey and do live patient surgeries or other courses we do, or if you want to see what I'm doing on the road. You can find all that stuff out at the RasnerInstitute.com. So let me get to it. Let me talk about it for a minute. Before I do so, I want to keep some general principles about case presentation that no matter what you're presenting, a crown and bridge case, where you're going to edentulate a patient and they're going to end up with a denture, or anything in between, I want you to go into the room. My advice would be to go into the room with a conservative mindset and let them know that. Say something along the lines of, I'm talking about to a new patient, this is what you're going to say. Now, again, this is a patient that has gone through the protocols that I've outlined in all these podcasts. It is not a random action that I end up with such high case acceptance, because as you've heard me talk about on these podcasts for the last year, that all begins at the first phone call. And if you haven't heard this podcast, you need to go back, open them up, revisit them, or write to me, because a lot of this I have in written form as well. Guys, let's just talk about it. This is everything, is it not? How happy you are, how able you are to cover payroll, how able you are to take extended needed time off and really be able to relax and take that time off, how able you are to contribute to a pension plan or give somebody a raise who's earned it and needs it in your office, or have the equipment to practice with that you want, has everything to do with case acceptance. I could be doing these weekly just on a new nugget for you, and maybe the new nugget will add, I had somebody write to me not so long ago that they got I don't know what they said, I think a $29,000 case using my principles. And listen, you need to hear me. I don't care that you get a $29,000 case. I care that you offered the treatment to a patient that needed it, that wanted it, and they accepted it. Whether it's 2,900 or 29,000, I don't care. I also don't want my colleagues negatized by the industry at a time when it's easy to be negatized, by toxic insurance reimbursement, by fickle patients that'll leave you because you're not in network, perhaps. So yeah, those of you that listen to me, this is my philosophy to help you out. And it's a philosophy that I have personally executed successfully. I've been practicing 39 years. I would say for a good 30 of those years, the philosophy you're getting from me on these podcasts is what got me to where I'm at today. So one of those things is that when I walk in the room, and I mean this, it's easy for me to talk to you like this on a great week or a great Monday out of a great week. It's a lot harder when you're in a slump, and we all, even I, go through slumps. I've been in a really hot period now, good period, for about 8 weeks. And I know it can turn on a dime and go dry for a month. And when you're in that month, you're like freaking out, thinking like, what am I doing that's any different? And it may be nothing. You've heard me say many times on these podcasts that you need 4 things to have a great week. Now, that's assuming you have great skills, that you've invested in your skill set. But what you need are new patients. Now, some of you just bought a practice and you have a lesser need than I do, and those of us that are established for new patients. But eventually you'll run into exactly the same problem, because the great weeks come from new patients, patients in hygiene that maybe weren't ready to make a commitment to work they need for the last 10 years. And for whatever reason, hallelujah, on Monday of the next week, you're surprised because your hygienist walks into your room and positive things tend to follow each other, don't they? When everything's going great, I don't know, it's a karma thing. That's the day you get that patient, the hygienist coming in saying, hey, Mrs. Smith, remember you've been talking to her about redoing a 10-unit bridge that she has that, facings are off of it and maybe from 35 years ago. And you weren't even expecting it. But that's the makings of a go week. But you need new patients. You need new patients with need. Sometimes they don't need anything. And that's fine. You need new patients with value of the need that you're going to recommend. I have weeks where, I mean it. I have weeks where I have patients that I don't get it. It doesn't matter what I say to them. They want to think about it. And I'm pretty standard in my protocol from the time they call me to the time I recommend in the chair. From everything that happens and the 10 different things that happen from the phone call to the time they're in my chair, I'm pretty standard on that. And there are weeks where it's just not there. So you need patients that value what you're recommending. New patients with need, new patients with value. And a lot of that value is what I'm going to give you right here today on the patient-facing and terminal dentition. And then the fourth thing is patients with the financial means to afford what you're recommending. And there are clearly weeks every year in my year where I don't get it. I don't even know why they came to me. They don't have any sense of credit. They have no money that they've put aside. It's absolutely demoralizing to me too, because what we do is so hard. It really is. And when it's going well, it all feels worthy, right? But I'm telling you this on purpose because I want you to know I mean it. I don't have extended months of that happening, but I have extended weeks, and it can be multiple times a year. And I don't change my approach, man. I don't. So here's what I'm telling you. Go into the room and be conservative. Tell your patient, sometimes I'll just say, and it's not the first thing I say, but I'll make sure I drop it. I say to them, I want you to know that I go into this exam room with the mindset of giving you the least invasive yet responsible treatment plan that I can. And I'm telling that words to a patient. And I do that on purpose because, number one, it's true. And I think it's a good thing to tell your patients. Because listen, it lets them put their guard down and trust you, which you want them to do. And if it isn't something little that you can offer, then it isn't. That's not your fault. But you went into the mindset of not you're going to change every silver filling you see into resin restorations. And you're not going to recommend a full mouth rehab to open up vertical occlusion on every patient you see with a collapsed vertical. And you certainly don't have the mindset of trying to convert a quota of patients per month into all on fours. You get me? That's not what I mean by I don't think like that a little bit. I want you to know, I don't have one quota chart, and nor have I ever in my office. That's not to say I don't have goals. I set goals in the beginning of the year, and that's a subject for another podcast where I have personal goals to make me personally. I'm talking more weight or working out, taking a vacation, goals with my significant other, my lady. For me, publishing goals or speaking goals, but I don't have quota goals, not at all. And I don't think you should. I don't think you need it. I think if you walk in the room like I do and follow my protocols, it'll take care of itself. That may sound simple, but I think it's true. I also try to be very positive about whatever I can be positive about with this new patient in my chair. Many of them took years to get in your chair if they're scared and fearful. And that I try to appeal, and I try to get you to appeal to patients with fear because it's a great patient. And if you use my oral sedation technique, it works 95% of the time, if not more. But I try to reinforce them whenever I can. So for example, if I have a patient with good bone, I'll tell them that very early on. Maybe they have rampant caries, but if they have good bone, I say, hey, first of all, I want to tell you something really good. You got great bone. I know that doesn't mean anything to you maybe right this second, but a lot of people don't have abundant bone like you do. And what that really means is it gives me options. And by the way, I always assume, and I have for years, that there's going to be a treatment plan given by me for this patient that has come into my office for the first time. I say that to you because I think in a lot of offices, the word treatment plan is foreign to a lot of patients, that they're treated myopically, meaning one-tooth dentistry for whatever it is that's wrong with them, that's obvious to them. And that practice often is also driven by the insurance of that patient. Look, you can't practice that way under my blueprint. You can't practice that way and deliver good dental health. You can't. That doesn't mean that they're going to accept everything I say to them or what you're going to say to them. I'm just saying I give a treatment plan, and all you got to, I've got at least 8 podcasts on treatment planning, and to extent, this one is the same today with a deviation about people with terminal dentitions. But whenever you can be positive, sometimes I'll say, you know what the best part about you being here today? It's 2019, and you have amazing options that I know about that I can offer you that we did not have even 10 years ago. And dentistry, if you need advanced dental work, whether it's a single crown instead of a filling, or whether it's a mouthful of dentistry, there's never been a better time to be in a dental chair because it's dramatically changed in the last several years. And it has, guys, and you know that. So, let's talk specifically about what I wanted this podcast to be about. We're talking about the patient that's coming to you, and maybe because of perio, or it doesn't matter to me, or due to rampant caries, multiple missing teeth, a maloccluded dentition, they are going from whatever they have in their mouth to something else that will be removable. I guess it could be fixed too. And that something could involve implants. It could just be a full denture. It could be a partial denture. Now, this is where I want to help you specifically. In my operatories, and you could start putting this together over the next 3 months, and I think you should. I think it's really important to be visual with the patient that is about to go through this. You know, when you and I talk about a denture to a patient that has all their teeth, or you and I talk about a partial denture, we think in our heads that, of course, they get it because they know people that have dentures or partial dentures. You shouldn't make that assumption. So I have several bins in my operatory. I don't have them in every operatory. I have them in my new patient examination room. And in those bins will be everything restoratively in an organized fashion that I can use. And I tell you that because I have used in the past elaborate videos that may show the process of losing a tooth and teeth drifting into each other and further dental pathology as a result of that. And maybe that is effective for some guys. It hasn't been in my hands. I find nothing more effective than having a patient in a dental chair, having a significant other in a dental chair, assisting chair, or actually recently, you should know, I invested in patient chairs that are portable to each room. They're really comfy. They're on wheels. And I like that more because I'm always scared they're going to fall out of the dental chair. The dental assisting chair, I mean. If I got that going on and I have my models, I find it incredibly effective. So this is how I talk. I would say, and now you know I go through my 5 areas of an examination. And I will do that even with these patients. And there's copious information on this from prior protocols, from prior podcast. And then I'll say, listen, and I say what I'm saying based on the vibe I'm getting with this patient. And to be quite honest, to be fair to me, it's so apparently evident that they're going to lose substantial teeth. The only thing I may say is, let me ask you a question. I don't think it's a surprise to you that you have a lot of decisions to make when it comes to moving forward with your dental health. Just curious, it's not a trick question. What made you finally come in? I think it's important to find out because sometimes patients in that situation in front of me are missing front teeth, very obvious front teeth. And I have converted many of those patients into comprehensive dental care patients. I mean it. And I find that stunning to me because if you're willing to walk around your community or life without front teeth for months or years, I would think your dental IQ motivation level to do something would be very low. I would think you could be influenced very quickly by cost to do nothing. I do think all those things. And I think it's really important for me to communicate, not to scare them, to just make them really understand. And I've been doing what I'm telling you with the 3D visual model thing for not a long time. I would say just a couple years. And it's grown. So I have a denture on a articulated model finished. So I will lean over and bring it into my lap. They're in the dental chair. And I'll say, so I want to begin with talking about options for you, because one of the ways that you could go, and right now I'm talking about just your upper teeth. Now, sometimes I'm not. Sometimes I'm talking about upper and lower arches. But I'm trying to give you guys a vibe, a feel for what's going on here. I said, I want to talk to you right now about a denture. This is a denture in my hand, as you can see. And I will take it off the model, the upper. I'll hold it in front of them. And I'll say, this is the kind of, these are the things I want you to know right now. That the palate is covered. Can you see? And it's very easy when you have the model that it came off of to show them and let them visualize this. This is a denture. And right at that moment, you will have patients, some patients say to you, I can't have that. I can't have something covering the roof of my mouth. Oh my God. Yet they might have gone for a denture. But you can't assume that they really know what a denture is. I mean it. And then you can go further and talk about things that I've talked about on these podcasts about, I'll say to them, look, don't kill the messenger. What I'm trying to do right now is figure out what would be okay for you moving forward. And this is what a denture looks like. So that's one way we can go. And by the way, I'm talking to you guys. Whenever I can break up upper and lower work, let's say, I'll think nothing sometimes of removing posterior mandibular molars that are unrestorable, and maybe maintaining second premolar to second premolar, or even first to first premolar on the mandible, even without a partial on there or posterior tooth replacement initially. And I'm going to tell you why I do that. And I tell the patient that. And sometimes it backfires, because if it is a full upper denture, if they only have six anterior teeth, you're asking for that denture to rock, break suction, and tip. I wouldn't do it in that case. But if they have premolars, I may try to transition them in. Listen, I don't want my patients or your patients to pay for things and me convince them of doing treatment that they'll end up a lower partial denture, for example, that may end up in their sock drawer. You get me? That's why I talk like this. And I wouldn't care if I made them an upper, regular, conventional denture and restored them either first premolar to the first premolar on the mandible or second to second, and they were okay with that in terms of function, I would be okay with that. I mean, I'm sure somebody can debate me on this. I'm talking about managing something called a human being. And if it was me, I would want to have as little in my mouth that comes in and out as possible. Okay, so keep that in your mind. When it's appropriate, I will then start talking about, well, another choice for you would be what's called a partial denture. And this is what I say to the patient. I'll say, now, when I say a partial denture to you, you need to know that that's like me saying I'm offering you a car, because there are 75 different types of cars. Which one am I talking about? And I will actually take out everything from a flipper, meaning an acrylic partial, with wrought wire clasp. Don't you have patients that come in and say they have a partial denture, and they bring out an acrylic partial, worn to bits, with 2 or 3 or 4 wrought wire clasps that are bent by hand, and that's what somebody's version of a partial is. This happened this week in my office, by the way. A woman shocked me. She'd been out without her molars for years. She has maxillary and mandible premolars. And she said, I want a posterior teeth, and I don't want to go through implant treatment. And I'd like to have partial dentures. And so I had this very discussion. And I went from acrylic with wrought wire to a precision partial of crowns made with a precision partial that fits in. Now, very often in my office, it is a hybrid case of where they'll have teeth maybe on one side of the arch and 3 implants on the left side with a bar. So there's obviously an abundance of very clinical treatment plans you could offer. I'm just trying to tell you how I get there. And it becomes very comfortable for you, and they see you as incredibly knowledgeable and caring, and they can make really good decisions based on that. I don't know if this sounds profound to you or you do it this way, but I like the 3D aspect of it because I get very concise and crystal clear feedback from the patient on whatever I'm showing them. You know, they see a denture. Oh my God, I don't want that. I see a partial denture with conventional clasping. Oh, I don't want those hooks. And it's really important that you can communicate that. I'm sure I'm not the only one in this audience right now that's delivered a partial denture, even though I tried it in on the patient at least one or two other times that had cast clasp and they never said anything about it until the final delivery. And then it also gives you a very easy avenue, if they have objections to this type of treatment, to lead into implant retained, either fixed or removable. I mean, it is no more complicated than that. I mean it. Now, look, don't feel bad if you're listening to this and you're overwhelmed a little bit, like, oh my God, so, what would I recommend if they had this situation or that? That's what you're doing right now and should be happy about and proud of, not overwhelmed. You are training. I continue to learn different treatment plans to offer patients based on technology that's available today. Is it locators? Is it a bar with locators? Is it fixed? Is it telescopic copings, which I'm a big fan of? And write to me if you want to know about that, because with telescopic copings on implants, I use a lab in Arizona from Arian Douche. If you want, write to me on that. So I like that variation because I don't have to take bone away with these patients. So that's just my personal preference, as opposed to, an all-on-4 situation. It's just my philosophy. I am very reluctant to take somebody, unless it was a traumatic accident, and put them in fixed that's about to lose all their teeth. I'd much rather have everything on my side to allow them to maintain the hygiene required for longevity of an implant retained restoration. Anyway, I hope this has helped you guys, as I hope all these podcasts help you guys. I think next week I'll be talking to you about, well, what do we do with a patient that isn't able to afford almost anything we're talking about? And that brings up a concept of a treatment plan I call putting out the fires treatment plan. So that's a patient that really doesn't want a denture, but can't afford implants and can't even afford multiple root canals and crowns and things. And, don't we need to offer them something? And I will give you that something next week. I hope you guys keep tuning in. I hope I get to meet some of you at some of my courses. My last course for this year is October 4th and 5th. It might be sold out, but you'd have to check with Beth. And even some of our courses, to be quite honest with you, in 220, and there's 4 times I give courses in my office, they're getting very full. And you know me by now. That's not a line. It's real. And I haven't had that experience prior to just recently. So if you're interested in my courses, please reach out early on. Most of the people that take them repeat them because, I customize them for whatever you want to learn regards to surgery. And any of you that have never taken them before, they're awesome. We numb the patients for you because we don't even want to waste time waiting for the patient to get numb. I hand select ASA 1s and 2s, so nothing bad will happen in the course, and nothing bad has ever happened in a course. So stay tuned. I hope I get to meet you. It's a privilege to do this for you. Thanks.